bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and the Children's Hospital Foundation of Manitoba. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. Hello, everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. So today's webinar is titled, What a Shame, the Impact of Mistakes on Healthcare Professionals. And as we have a really interesting and exciting panel to bring to you today, we're very excited about. First off, on our panel, we have Diane Aubin, and I'd like to thank Diane for bringing this topic to us. She actually participated in one of our presentations that we gave on CAFC's new strategic plan, and she wondered if this topic might be relevant and related to our new directions, and of course it obviously was, and we had a great conversation following that, so thanks, Diane, for bringing this topic. Diane is a doctoral candidate in the Department of Educational Psychology at the University of Alberta, and has recently completed a qualitative study for her dissertation on the psychological impact of mistakes on health professionals that are working in pediatric hospitals. And we're going to hear lots more about that in the remaining parts of the presentation. Diane's interest in this subject stems from previous work that she had done with the Canadian Medical Protective Association, the CMPA. And she is now currently working leading research projects for the Canadian Patient Safety Institute, and Diane is joining us from Edmonton, Alberta. I'm also very excited to welcome a familiar name to many in the audience, Dr. Brian Goldman, and probably most well known for his appearance at the 2010 CAFC Annual Conference in Ottawa. Okay, maybe that's not how everyone knows him. I think probably most people know him from his appearances on CBC and his podcast and radio show White Coat Black Art. He's also a veteran physician and at Mount Sinai Hospital in Toronto, an ER physician. He's also part of CBC Television's The Health Show, as well as on The National. He's also known as CBC Radio 1's House Doctor, and he has proven a knack for making sense of medical bafflegab. He also has a couple of books that you may have read as well. The Night Shift was Real Life in the Heart of the ER, and more recently, he has in the last year he released his second book, The Secret Language of Doctors, which explains the phrases doctors use to describe patients' situations and even the colleagues that they don't necessarily like. So really excited to bring Dr. Goldman here. I'm a real fan, so I'm a little bit more nervous today than I usually am, but it's going to be a really great presentation today. So without any further ado, it's my pleasure to hand the virtual podium first over to Diane Aubin out in Edmonton. Over to you, Diane.
Well, thank you very much, Doug, for the introduction. And are we seeing my screen yet?
I'm seeing it.
Yes. Good.
Yep, we're seeing it.
Thank you. Okay. So, yes, thanks for the introduction. And as you mentioned, I just want to say a little note that I do indeed work for the Canadian Patient Safety Institute and proud to be an employee there. But as you can see from the title slide, I am here not representing CPSI, but wearing my researcher hat. So if I say something controversial, it is my controversy and not the CPSI's. So that being said, I'm very pleased to be here and feel privileged to share my study and also to share the stage with Dr. Goldman, so to speak, to talk to you about my stories and thoughts from my study on health professionals and mistakes and the emotion of shame. So as Doug said, I really hope this will be interactive. I know Dr. Goldman feels the same way. We'd like it to be more conversational and invite you to use the chat at any time for comments or thoughts you have or any kind of questions you have. So with this in mind, I'm going to get you engaged right away, thinking about the emotion of shame. This quick exercise will also hopefully get you used to using the chat function so that you can use it throughout the webinar. So I want you to think about a time when you felt shame. Now, it doesn't have to be around mistakes. It doesn't have to be as a health professional. Just any time in your life when you felt ashamed of something you did, that panicky feeling. And fill in the blanks. So take yourself back to that time and think of what word would you have used to describe yourself.
So just into that chat box that I mentioned earlier, just type in, a word, maybe just separated by a comma, the two words that explain you are and you feel, and just type those into the question box.
And just a note that nobody else can see, other than Doug, no one else can see what you're typing in. So if you don't see anything coming up there, it's because nobody can. So there could be hundreds of words there already, and you don't know it.
Yeah.
I know. I took a risk. It's right at the beginning. It's right at the beginning of but there you go.
No, we've already got we've got lots of people who have experienced shame apparently out here, because we've got lots of input. The first one came in that said, "I am an idiot and I feel stupid." Another one was, "I am embarrassed." Another one said, "I am sad and I feel disappointed." Another one, interesting one, said, "I am young and I feel stupid." "I am stupid and I feel worthless." "I am a failure and I have no confidence." "I am embarrassed and I feel afraid." "I am angry and I feel ashamed." I'm nauseous and I feel disappointed." I am such an idiot and I feel so embarrassed." Lots of, they're still coming in. Lots of embarrassed, lots of feelings of being stupid. "I am a horrible person and I feel ashamed," et cetera, et cetera. You can see lots of great feedback. Thank you everyone for putting that all in.
Oh, thank you so much. And you really are reflecting a lot of what I heard from the participants. This feeling of worthlessness, of feeling stupid. It comes up again and again and again. Very interesting about feeling young, and we're talking about people who treat you differently because you just started, and these are all these words are words that participants used. And I'll just give you a little bit of a sample of what the participants said to me. I spoke to 21 participants, doctors, nurses, and pharmacists at 2 children's hospitals in Canada, about the shame they felt after a mistake. And they taught me a lot about how they coped. Gee, I wish I could talk to each and every one of you out there who shared. So I guess I should close this. Whoops. No, I don't want to leave the webinar. I'm just going to move that over.
That arrow that's pointing to the right, that'll get that out of your way.
Got it. Okay. So one of the people, that would have been a disaster. That would have been a really bad mistake. So one of the participants said, at that point, I just remember feeling very hot and sweaty. So that's some of the physical reaction. I remember I couldn't look her in the eye, meaning the patient's mother, the baby's mother, because I just felt so awful. Another person said, it's almost like you failed as a person. And somebody said that. It's like you feel like a failure. I was ashamed of being stupid enough to make a mistake like that. There's that word, stupid. And again, this is a physical reaction. And my stomach and heart just dropped down to my feet. And I felt really bad because I was like, I almost clotted this child's line off. It's a very visceral or fight or flight kind of reaction that just pounds you. My heart just leaps right into my stomach and my throat. So definitely reminiscent of your comments, and thank you again for sharing so quickly. So just to make sure we're all on the same page about shame, I just want to describe a little bit about what I think it is, or what I've heard it described. And basically, it's what we feel when we believe we've failed to meet our own standard, goal, or rule. So for example, my standard is to be honest and truthful. And when I lie, I feel ashamed. So I have this standard and I haven't met it, so I feel shame. Another way it's been described is an intensely painful feeling or experience of believing we are flawed and therefore unworthy of acceptance and belonging. And this is Brene Brown. Many of you may have heard about her through her TED Talk. And I'll provide that link, Doug, after the presentation. Really, she's got fascinating thoughts about vulnerability and shame. And she's quite well known. She's even been on Oprah. I don't know if she's ever been on Dr. Goldman's show, but she's been on Oprah.
We'll have to book her.
Yeah, you'll have to. So that's her description of it. The other way it's been described as one of the most powerful, painful, and potentially destructive experiences known to humans. So very powerful and important emotion. So that's a little bit about what shame is. But why is it relevant to health professionals? Well, I think you can probably already start to guess why. Health professionals have very high standards for themselves. In fact, many of you know that there's a tendency for health professionals to feel a pressure to be perfect, right? To not make mistakes, to know everything, to perform at the highest standard, despite the fact that you are working in a very complex environment with time and resource constraints, organizational pressures, and really the critical nature of what you do every day. So you're taking care of people and very sick and vulnerable people. And it's no wonder that shame is prevalent in healthcare. And health professionals just simply can't maintain or reach that high standard for themselves in some cases. So what became clear to me during the interviews and then as I listened to them again is that health professionals must constantly portray themselves as trustworthy, competent, and infallible toward their patients and colleagues. It's how they build trust with each other and with their patients. So it's as though health professionals must wear a mask, and I call this the mask of infallibility. So this mask of infallibility allows them to appear perfect to the outside world, and in the process, maybe even convincing themselves of their infallibility. But even if they don't believe it themselves, in order to function, they need to convince others that they know what they're doing, they can be trusted, they won't make a mistake, and they're not going to harm the patient. But behind this mask is what we all recognize as a fallible self. So we know that we're fallible, but even though we know that deep down, some more deep down than others, we try to hide behind this mask of infallibility. So what happens is that when we make a mistake, this mask starts to erode from inside and from out, but it erodes from the inside, from the way we feel about ourselves. And all these emotions that you shared with me, this is part of that erosion. Is all of a sudden that mask you have of being perfect is, wait a minute, it's all being eroded with things like self-doubt. So here's a male physician who spoke about what he felt. I'm always thinking, if I had done that, would it have made a difference? In my case, the baby I sent home died. So you always wonder. So he's full of self-doubt. Similarly, participants talked about self-criticism. We tend to criticize ourselves when we make a mistake, believing that we're not good enough. I think some of you talked about being disappointed in yourselves or feeling like a failure or worthless. So one of the resident participants talked about how she says, I know I'm hard on myself, which is not good for my mental health. So she recognizes that it's not good for her, but she does criticize herself. The other thing is the mask erodes from within because of irrational thinking. So we have all kinds of irrational thoughts. And here's some examples from the participants. I must be perfect. Well, I've already talked about that. This is a catastrophe. So any little mistake becomes something huge. All of a sudden, oh my goodness, I am worthless. Even if it didn't cause harm to the patient. I found it didn't seem to matter whether the patient was harmed or not. It's the potential for harm that can be devastating. I am the only one responsible for the mistake is another irrational thought. And we know from all the work around systems thinking that it's not usually the case that one person is responsible for the mistake. I was thinking of an example this morning about one of the nurses who was just devastated because she had injected the wrong dose of a drug, but it had been given to her in the wrong dose. But I said to her, well, did you ever think about maybe the pharmacist or people along the way felt just as bad as you did? And she says, no, I never thought of that. So you're really focused on yourself. This one, I'd love to hear your thoughts on this later on. Somebody said, I must continue to carry the shame so that I never forget. So they feel, even years and years later, that they should continue to feel this shame, to carry it around, to to almost pay homage or to honor the victim, the patient victim. If I make a mistake, people will respect me less, trust me less. Maybe that's the case in some cases, but this one nurse was telling me how she really felt well respected and valued. She did a really, really good job, and she made this one mistake, and suddenly she thought nobody would trust her ever again. And another irrational thought, and you've heard this already, I am stupid. This last one, I'm wholly responsible for any bad outcome for the patient. We all know that some bad outcomes are from the disease process. It may not be because of the mistake. So that's how the mask erodes from the inside, and as I mentioned, it can also erode from the outside. So your exposure to other people, to other factors on the outside. And I'm sure you're starting to think yourselves about some of the ways that can erode, or how you can be exposed from the outside. One is through judgment about your mistake from other people. Even if you only perceive the judgment, it still erodes that mask of infallibility. A very compelling quote from one of the nurses said this, I quote, I always feel like they're hanging out at my back saying, oh, you're such a loser. You're so stupid. You made this mistake. God, you're dumb. And look, you're getting so old. Maybe it's Alzheimer's. I always will continue to feel that way around them. I don't know how long ago that was, maybe 3 or 4 years ago, but I still feel that way about those people. I don't particularly like being around them because I feel vulnerable around them. And notice that she mentions she feels she might be judged because of her age, because she's old, not because she's young. So another form of ageism. I also found that there was a lot of bullying, and in one of the hospitals in particular, a lot of talk around gossiping. And I'm not sure if it was CAFC, or I heard a webinar not too long ago, somebody talking about bullying. Was that a CAFC presentation, Doug?
I don't know as we had one specifically on bullying, but we often have we have them from our Children and Youth and Challenging Contexts group. They've brought some content around that has included content on bullying for sure.
Right. I'm thinking now it was either the Ontario Nurses Association or the Canadian Nurses Association. Again, please remind me to send that link because I think it was recorded. So bullying can be the gossiping or teasing or shaming. Some people describe this gossiping as being dragged through the mud, or that joking, that teasing that goes on that just really isn't funny to the one who made the mistake. Mm-hmm. Blaming, not a big surprise. It's still going on. Despite this commitment to just culture and systems thinking, on the front line there seemed to be still a lot of whispering about blaming. Another way health professionals feel exposed from the outside is the silence and the isolating around the mistake. There's a reason probably that people don't want to come up to you and say, oh, I heard you make a mistake. Are you okay? You don't want to re-expose them, so you kind of avoid them, avoid looking at them in the eye, and don't talk about it. The elephant in the room, but it actually also adds to the person's shame because they feel abandoned. And the last surprising finding I found was that a lot of the organizational processes that help us learn about mistakes are really can be very distressing emotionally for it wasn't a surprise that they were distressing, but it was a surprise at how visceral the reaction was to these processes, like the debriefings, the M&M rounds, incident management processes, investigations, and educational sessions. They're all good, but something about them is making that person who made the mistake feel even worse. One thing I don't want to lose sight of, and I haven't mentioned shame in the last few minutes, is that shame is very deeply embedded in all of this erosion and exposure, and we can't lose sight of that. I like to say that shame is the acid of the erosion, and the harsh sunlight of exposure. But don't take my word for it. I'm going to read out, it'll take me about 2 minutes to read out what one of my participants said. She was so insightful and had some very compelling words about shame and how it's embedded in all of this. And she was very emotional when she was telling it to me, so I'll try to convey some of that emotion as I speak to it. When you look at the word shame, first of all, it's shh, meaning I've got a secret, because most of us don't want to talk about it. We're already exposed. We've already put ourselves out there and exposed ourselves for something that we were never meant to be. We weren't meant to be careless. We weren't meant to be untrustworthy. We weren't meant to be stupid. We weren't meant to be a dummy. We weren't meant to be an idiot, and yet we've just done that. All of those things we've just done by making the mistake. So it's all you want to say is, shh, don't tell anyone, don't tell anybody I'm all those things. The end of the word shame is me. It's all about me and who I am and who I suddenly am not. I thought I was a competent nurse. I thought I was going to protect this person, and guess what? I didn't do that. It's about my identity. Because now it's shushed. It's all out there, totally exposed for everyone to see. The other part of shame is the first part of the word, S-H-A-M, is sham. You've just seen that I'm a sham. And it's a very isolated thing. And because it's about identity, and because it's no longer shushed, now I get to see in your eyes what you think about me. So everything you say to me, everything that I see in your eyes just reinforces that I've done, that I'm not a good nurse. I'm not the protector. So I'm going to pause here. I've talked about how health professionals are predisposed to shame because of the high standards they've set for themselves. I've also talked about the mask of infallibility they have to wear to hide their fallibility to the outside world, and how it erodes from the inside and out when they make a mistake. And we've just seen with these compelling words from the participant how shame is deeply embedded in the process. So before I talk about how health professionals cope with the shame they feel and how they keep that mask from eroding, I'd like to pause to ask Doug if there are any comments or questions.
Yeah, so as I said at the beginning, if you do have any comments or questions, please type them into that question box that's in the bottom of the control panel. That's usually on the right-hand side of your screen. We did have one comment come in from Ron, and he said, it's important to learn what occasioned the shame, to do things differently the next time around. So to use the experience as a learning opportunity, perhaps.
I like that, learn what occasioned from the shame. So not so much learn what went wrong, but learn about why that person feels shame. Mm-hmm. That's how I interpret that comment. If I've interpreted it wrong, please correct me, Ron.
Yeah, Diane, Brian here. How do you separate the learning potential of shame from the more emotional reactions that seem to be kind of reaching to the core of the people who you spoke to through your research?
Mm-hmm. I'm not sure that we can separate, but what we can do, and this is what hopefully we'll talk about all together at the end, is that we can be more discreet, and be more cognizant of the emotions and the experience that person is going through when they make a mistake. One person said, they come through the quality people come through the unit with, and everybody knows why they're coming to the unit there, and we all look to see who made the mistake. So there's a way we can still use these processes but make investigations not so much about inquisitions, but about understanding and respect.
All right. We did have another comment came in from Sharon. She says, excellent observations and insight into the feelings and actions of us, meaning healthcare clinicians in these situations. She says, what should organizations, leaders, managers do to help us in these situations?
And I'm going to throw that question back at you at the end. I don't want to preempt that too much, but this discretion definitely is one thing. I think we need to look at processes or protocols to be put into place to take care of the individuals who are involved in the mistake. I know we have employee assistance programs. What I heard about them is that those who are helping in those situations through employee assistance programs don't necessarily understand the context. Maybe people feel that the organization is still going to know that they're going, that it's not really as confidential, so they doubt the confidentiality of that program. So they're feeling like they need to talk to people who understand, who've been through this, who understand the context of healthcare. But I think organizations can do a lot more to take care of that individual involved in the mistake. And I have some other ideas, and we can talk about them at the end as well. But I think we've forgotten the individual in systems thinking. We went from blaming the individual to thinking about the mistakes as more of a system problem, and we've taken the humanness out of the mistake, and we need to bring that back in.
Mm-hmm.
All right, excellent comment. That's a great thought to perhaps move on into the next segment of their presentation.
Okay. So here's my little mask again. I have to bring myself back to where I was. Okay. So it's not all bad news. It's not all doom and gloom, of course. Most health professionals survive mistakes and they thrive. They learn from their mistake and move on. And they do this by reinforcing themselves, and what I call reinforcing their mask against this erosion. And they do it maybe by containing the mistake. Containing can mean by maybe not even telling anybody about the mistake. I think there are a lot of mistakes. We know a lot of the mistakes, only 5% get reported. But I think among the rest of the 95%, I think only the individual who made the mistake knows about it in some of that 95%. So they might think it's just a minor error, nobody was harmed, I'm not going to get too upset about it. So that's containing the mistake. Another way they might reinforce themselves against exposure is by saying, it's just bad luck. I was just there at the wrong time. It could have happened to anyone. It's no big deal. It's just random. The word random actually came up quite a bit. And similar to that bad luck or randomness is being human. People talk about, hey, I'm only human, and that distances them from the mistake. So one of the participants said, she was a pharmacist, she said, at the very core of it, you're still human. And there are so many things buzzing around you. What can you do? I'm surprised we don't make more mistakes. I think we're doing pretty good thus far. So she's containing. She's saying, hey, I'm human. I'm doing pretty well. The next one is probably not surprising to many of you, is one way of protecting that mask of infallibility is blaming others. So not taking responsibility for the mistake, blaming others. So you're still infallible. And there's so many ways we rationalize our mistakes. Now, I'm not saying this is necessarily a bad thing, but this is just a way we protect ourselves. And we analyze what went wrong, recognizing that healthcare is complex and there's no black and white answer. So those are some of the ways we rationalize why the mistake happened. And that's a good thing, and we learn from that. And the impact is not the same on everyone. That's probably pretty clear to you that there are some people, they don't erode that mask. They still maintain this mask of certitude and I'm right. It's not my fault. Someone else's blame. I'm always right. I'm still perfect. So there are very, very few, but there are some, and I'm probably seeing people nod their heads knowing someone who is like that. And at the other end of the extreme are those who remain unmasked. So they have, their mask has totally eroded. And Dr. Goldman and I were talking the other day, and he used the word shattered. So their mask is totally shattered and can't be put back together. So they're not only see themselves as fallible, but as a failure. So their mask is beyond repair. But between those two extremes is everyone else, and the majority of health professionals who do recover from their mistakes and realize they're fallible. They've acknowledged their role in the mistake. They've grappled with the emotion of shame. They've rebuilt their confidence and allowed time to heal their wounds. And they're thus able to slowly tackle the job of reinventing themselves as less than perfect. But even though they're less than perfect, they still feel worthy of being a health professional. So that is my part of the presentation. When I first started this study, I must admit that I thought the solution should be, well, let's make the whole environment psychologically safe, and let's open the doors wide open, let's be totally transparent. But the stories and the emotions that, the emotions I heard from you this morning, the emotions that I heard from the participants really made me stop and say, well, we do need to be more open, and I know Dr. Goldman will talk more about this, but we also need to be more discreet. We need to open that door just enough to show people it's normal to make mistakes, and it's not that it's the best thing, but that it's normal, that you're human. It's human to make mistakes, but not so wide open that those who are feeling shame about mistakes feel exposed and vulnerable. So as I mentioned after Dr. Goldman's presentation, I'd like to have a discussion about what we can do in our culture, in our organizations, and in our education. Let's talk about how we might prepare health professionals for these feelings and for mistakes. So I have some ideas, but I'd like to hear from you too.
All right. Well, we do have a number of comments that came in, and quite a few of them are around are there any strategies, or how do we support colleagues, or how do we change organizations to help those that are feeling shame? So maybe we'll save those comments for afterwards. But one interesting one came from Jennifer, and she says she's struck by the impact of our learning methodologies. She puts learning in quotes, M&M rounds, incident analysis, etc., and the impact on the individual. And perhaps we need to rethink how we do this.
I agree. That's definitely what I found, and I'm hearing from your comment that you have found that too. And we need to be. I think we've just gone, full force into, yes, we have to learn from everything, and it's a good time to stop and think about what it's doing to the person who made the mistake. Thank you for that comment.
A comment came in from Leslie. At their organization, they ask all staff that are involved in an occurrence if they would like a debriefing with the critical incident stress management team. She says this is a confidential process, and staff have identified that this is a helpful approach. She says one small step in supporting their staff, at least.
Excellent. That sounds like it's a good best practice model. Can you read what it was called again? Critical Incident Management.
Critical Incident Stress Management Team.
Thank you.
Yeah. And Sharon is asking, is there a dynamic with the patient or family that can help almost immediately, and using discretion when these things happen? Will this help healthcare providers more immediately? Generally, it does help pave the way for healing with the patients and families, at least.
I'm going to guess which Sharon that is. I'm guessing, I won't reveal her real identity, but thank you for that, Sharon. There's CPSI has a Patient for Patient Safety Canada program, wonderful group of individuals who have been through an incident with either their loved one or themselves, and they volunteer to spread the word about how we can engage patients in keeping patients safe. And I have thought about this. I did not interview patients for my study, But the idea, and I didn't mention this, thanks for bringing it up, for some individuals, disclosing to patients does help them forgive themselves, does help them cope. And obviously that's what patients want to hear too. They want to hear, I'm sorry. They want to hear honesty, and they want to feel they can trust that person again. For some health professionals, one participant said the longest walk he ever did was walking down that hall to talk to the parents of a child who was harmed. So it is very uncomfortable, and well, that's saying not saying much, but it was a very distressing moment for him. So we can work a lot on that particular process, the disclosure process, to help both the patient and the health professional.
And Sharon did say it's okay to reveal her identity if you wanted to do that.
Yes, Sharon Nettleton. Sharon Nettleton is I believe you're now the chair of that group, Patients for Patient Safety Canada.
It's Elaine. Diane and Sharon is very, very well known to the CAPC community as well, and was recently, actually 2013, was a presenter at our National Patient Safety Symposium. So hello to you, Sharon.
All right. And we also had a comment come in, and we'll take one more before we move on to Dr. Goldman. Tracy has said, I understand some organizations have a second victim policy or protocol. She hasn't been able to find many examples, but the idea is to support the providers involved in the critical events.
Right. I have my thoughts about the term second victim. And I welcome comments about that. But there is like Sidney Decker and Albert Wu do talk a lot about. Albert Wu was the one who did coin the phrase second victim, and I think it really is. They've done a lot to have us pay attention to the health professional as the second victim when a patient is harmed. I have some concerns, one, that health professionals, because they see themselves as perfect, also don't want to see themselves as a victim. That's very difficult for them to see themselves as a victim, especially when they care so much about the patient who's been harmed. They don't want to take away from that. And I think about, like, if I heard about an accident in the paper about an individual who, maybe a family was killed because somebody was negligent and went over the line and ran into their car. The victims in this case are the family, the mother and child. And the second victim in this case was the person who went over the line and caused the accident. I'd have a hard time with that term, so I'm not sure why we're okay with it in this case. So I welcome your thoughts about that. Well, but definitely it's a great thing that we are paying attention to that second victim.
Yeah, we did.
I think it's Brian here. I think it's an acknowledgement that there is another party that's harmed, and it's been very, in the culture of shame that we have in healthcare, we often find it very difficult to do anything other than blame that person and make them feel as awful as your research has uncovered.
Number of comments come in about sort of the negativity around the term victim, and totally agreeing with the sorts of things that you were saying there. But so why don't we move on? We do have a number of other comments, lots of them talking about how do organizations change, or what should they do to help the individuals that experience this shame, sort of the sorts of things that Diane said we wanted to get to at the end of the session. So why don't we move on to go from Edmonton over to Toronto with Dr. Goldman and hear a bit of a personal experience more firsthand this time. So over to you, Dr. Goldman.
So thanks very much, Doug. We've had from Diane a wonderful recitation summary of the research that she's working on, kind of an outside perspective looking in, and now let's flip the lens 180 degrees to the inside perspective looking out. And let's begin with a case that I'll quickly run through. So this is the story of a woman with a history of psychosis and a recent admission to a psychiatric hospital. She was brought to the emergency department presenting with head and neck injuries from a fall, and she arrives on a backboard and a collar. She is seen by an experienced first-year resident late in that PGY1's year. The patient has a history of alcohol and drug abuse, and as I said, arrives on a backboard and a collar. She's confused. She doesn't speak English. Her vital signs are stable. The resident reports that there's nothing of note to find on the physical examination apart from head and possible neck injuries. Neurological examination is completely normal, and so the working diagnosis is a fall related to intoxication, rule out significant head and neck injuries, and was this because of the confusing words coming from the patient, was this an exacerbation of a pre-existing psychiatric condition? So the plan was to order standard blood panels, so electrolytes, ethanol levels, ASA, Tylenol, urine testing for intoxication, for intoxicants, and to do a CT scan of the head and neck, looking for signs of a subdural, looking for a fracture of the neck, and then the plan was to remove the patient from the backboard and collar if there was a normal CT, to obtain previous psychiatric hospital records to corroborate that part of the story, and then eventually to transfer the patient to a psychiatric facility once they were medically clear. The CT of the head and neck were normal, so the backboard and collar were removed. The previous psychiatric history was verified. Now, along came a critical lab report. Critical, that's how it comes from the lab, of an elevated liver enzyme test. It was shown to the attending physician. The physician had no concern because there was a known history of alcohol intoxication. It didn't register as something that needed further examination. There was a time, this patient spent several hours in the emergency department, and there was a moment when the attending staff was at the bedside with the resident. The attending staff noted there was a significant language barrier. The patient, however, didn't appear to be in any distress, and the attending staff asked the resident to use the language line if necessary to obtain a translation. This was not done, and sometime after that, the patient was transferred to a nearby psychiatric hospital. The patient was seen by the psychiatric staff at the hospital, who felt that the patient was quote-unquote sicker than expected given the fact that they were cleared medically. We call that medical clearance. And looked at the full blood panel, noted several severe lab abnormalities, one in particular indicating kidney failure, a very high creatinine, and severe acidosis, a low bicarbonate, and elevated anion gap. And so the patient was transferred back to the acute care hospital for further assessment and management beginning in the emergency department. Upon reassessment by a different attending physician, this patient was found to also have a fractured pelvis, and this patient was admitted to the medical ward. The acidosis was corrected, and the kidney function improved with intravenous fluids. There was no obvious cause for the various metabolic abnormalities. There was some alcohol on board, but it was not certain whether that tied in with the acidosis. The lactate was a little bit elevated. There was some thought that perhaps the patient had been dehydrated and hadn't been eating for a while. The confusion resolved, but the patient was still found to be psychotic, and so was transferred back to the psychiatric facility. So we would call this a near miss. And Diane's already talked to you about some people that she interviewed who were part of very grievous outcomes, and others that could be classified as near misses. This was a near miss. So now we move on to the investigation of the incident, which begins with the all familiar, an email with either a phone call or an email with the three words that, in the lexicon of an emergency physician are the three worst words, and they are, do you remember? Do you remember a patient named so-and-so? The chief expressed concern about what happened with the patient, that the patient in particular was transferred without being medically stable, had to be transferred back. And so an investigation began. And some of the outcomes of the investigation, the chief was critical of the attending's failure to supervise. The question was asked, is this how you supervise residents? The attending physician whose actions were being criticized was told that abnormal critical liver enzyme should have prompted the attending to check all of the blood tests. And the attending said in reply, a number of things focused on the resident, but that topic was quickly dismissed, and then the attending also said in defense that had the nurse in the area should have spoken directly to the attending, bypassing the resident, if that nurse had concerns about the patient's welfare. And the answer to that was that the nurse had charted a concern about the patient's level of awareness, which of course had prompted the CT scan, which was normal. So that was the end of the back and forth about what had happened. There was a letter that was written naming the attending as the major person at fault. The resident was not cited despite missing another similar kidney test result on another patient. And kind of the final parting shot was, we're going to have to do an M&M about this. And the flavor of that was that it was a punishment. That see what you've made us do. That was my patient. And so the first thing I want to say is that I certainly believe that in a complex system, errors happen all the time. Something like this doesn't happen every day in my experience, but a wise person told me a long time ago that something bad will happen every few years if you work long enough in emergency medicine. And to me, that's certainly the case. And a lot of it has to do with luck, fortune, fortuna, if you want to call it that. But I can tell you that personally, the shame that I felt was all-consuming. I had difficulty sleeping for weeks, I would say months afterwards. I felt small. I felt if I can put words to the shameful feeling that you have, it's almost like every good thing you have ever done to that point in time will now be ignored. It's as if it was as if my life script were being rewritten before my eyes. Oh, Brian, we have been waiting for the mistake that will forever, now and forever, label you as a flawed person. And this is the script of your life. This is the story of your life. That's the kind of feeling that I have experienced. And it's not the first time, and it won't be the last time, and I've certainly seen it in my colleagues as well. I'm thinking of a colleague who saw a middle-aged man with some nausea and vomiting, and he thought that the patient might have an obstruction, did some x-rays. The x-rays looked fairly normal. The patient said he wanted to go home. Went home, and within 24 hours had died of an ischemic bowel. So he was obstructed. He had an ischemic bowel. You can argue as to whether or not he should have had a CT. Now my colleague was sued and went through several years of discovery and trial, and eventually no negligence was found. What's interesting about this is that you don't have to be found negligent or have a college find your work to be less than exemplary or in perhaps even below the standard. Maybe you get a written caution, maybe you get a verbal caution. You don't have to have something like that happen to feel shame. You can feel shame in casual conversation if somebody asks you, did you do something, and you didn't do it. And we often feel shame at handover. Very often at handover, if you're going home, you might have to sign 1 or 2 patients over, maybe 3 or 4 patients over, and maybe it's a patient who is of childbearing potential, and the colleague asks, did you do a pelvic examination? And you say you didn't. You're not going to tell them that you didn't have a lot of time or you thought they were stable. You're immediately going to feel a sense of shame. In fact, you might even you might even excuse yourself and go and do the pelvic examination before you hand the patient over. That's how we feel. That's how all pervasive shame is. And I would say, why do we feel the shame? Diane has already talked about internal factors, external factors, the perfectionism that I think we bring to the table. And And there are many, many reinforcers in the culture of medicine, both within medicine, within the hospital sliding doors, and also in the culture at large. All you have to do is pick up the newspapers and read the name and shame journals, the daily journals of naming and shaming people in power, including physicians or people in perceived power. But there is this cultural belief, and I love, in my TED Talk, I love to talk about batting averages. This is an image of Miguel Cabrera of the Detroit Tigers, who won the Triple Crown in 2012 for leading the league in homers and runs batted in and batting average of 330. And I love to ask people, how would you feel if you had a surgeon who was batting 330 at appendectomies? Probably not very good. So for those of you who don't know baseball, a 330 batting average means that you hit safely 33 times out of every 100. So that means that guess the other 67 times you don't. So clearly that's not a very good batting average for a health professional. So what is an appropriate batting average for a health professional? And I would submit to you that it's supposed to be 1,000, meaning you hit safely all the time. You never, ever make a mistake. And so the system-wide assumption in healthcare, never mind, I know there's a lot of lip service paid to system errors, and we all know they happen, but there's this gut feeling that nobody ever makes a mistake. And so mistakes are a red flag for incompetence. And this has many, many repercussions, but one of them is why spend a lot of money detecting errors and mitigating damage if no one is ever supposed to make any? And I would submit to you that that's the major reason why it's only recently in the last few years that as medicine has gotten inexorably more complex and more errors with the potential to harm have been revealed, that we finally have realized that we can't simply pretend that nobody makes mistakes, because it's evident that we do. Of course, how you bat 1,000 is the health professional's problem. But I can tell you from my own personal feelings and from talking to colleagues and having many colleagues confess to me, because once I gave a TED Talk and talked about my worst mistakes, people realized that maybe I was somebody they could talk to, that errors in medical culture are viewed as either a momentary lapse or a momentary bout of laziness, a brief personality lapse, or a pervasive pattern of incompetence. And so take your pick. Which do you want? And most of us will wear sackcloth and ashes, and we will accept, when somebody tells us all the things that we did wrong and what we were thinking when we did wrong, instead of asking us, telling us, we nod and wear the mask of shame. That's a different sort of mask, I guess, than the one that Diane was talking about. And this is the reason why we hope that no one will discover a second error too few weeks or months after the first one, because that suggests a pervasive pattern. The impact of shame, we have personal shame that makes us feel awful and can lead to depression and even suicide. The risk of completed suicide in health professionals is much greater than that for the general population. We're healthier in almost every other way but that. And errors are not always, but not infrequently at the root of depression and suicidal ideation amongst health professionals. So on a personal level, it makes us uncomfortable. That silence that Diane talked about, if I start talking about my mistakes to a room full of colleagues, I better pick the right group of colleagues, because I can guarantee you within 5 or 10 minutes, somebody will make a joke, everybody will laugh, and then we'll move on. And there's a good chance that I might be the only one talking about my own mistakes. As a result, we're uncomfortable teaching others about our mistakes, and we're uncomfortable learning from them. And in fact, sometimes we even reject the new knowledge and wisdom that comes from a colleague because, well, Goldman made that mistake, he's flawed. And the assumption is, not there but for the grace of God go I, but, I'd never make a mistake like that. That's our gut reaction. What's interesting, Diane, that I find is that we find it easier, I think, to explore the shameful episodes of our colleagues, but only just a bit more. If I know that somebody's taken the wrong leg off in my hospital, and it became, part of the gossip mill that you just talked about, I'd have trouble making eye contact with that person. So we feel vicarious shame very strongly. We probably feel it a bit better, a bit more clearly than our own shame, which is more pervasive and amorphous. And I think that's only because it hurts less when it's somebody else than it does to us. Now, what are the good things about shame? I think at the leadership level, leaders of hospital are highly sensitive to loss of public approval, which makes them want to resolve the problem and restore public faith as quickly as possible. And the easiest way to do that is to find somebody to blame. And in fact, there is a bit of hospital slang called blame storming, which is doling out blame for mistakes usually to the lowest healthcare professional in the hierarchy. I would also suggest to you that shame is good because at the hospital level, because it reinforces the silence that Diane was talking about. So then we come to the question, and I think this is a good juncture to stop and answer questions. What do we do about it? What do we do on a personal level, and what can we do on a system level?
All right. Well, thank you very much for that great scenario that really brings it home, I think, for everybody in the audience there. We did have a comment come in from Maureen that was interesting, and then we have lots of those comments and questions about what do we do about this, as Dr. Goldman just said. The comment that came in from Maureen says, in her experience has shown that many nurses, regardless of a no-blame one-on-one review, or even if it's a case where the error never actually made it to the patient, the nurses can recall almost to the day when they made or almost made a major mistake. She says they carry it for their entire career. So I thought that was very telling of the long-term impact of these mistakes. So let's go on to that piece about what do we do about it, and maybe we can hear from Dr. Goldman and Diane and any comments from the audience, of course. But the questions are along the lines of: are there any strategies or support the colleagues or organizations can take to help those feelings of shame? And Samina said, thank you for a tremendously thought-provoking and frankly emotional presentation this morning. Can you make some suggestions as to how you think we can move forward to help these healthcare providers with their healing so that they may continue to provide the great care that they do? So how do we move forward? What do we do for these people?
I thank you for your comments. I think there are different levels. What one of the last comments talked about is what can we do for that individual, or what can the individual do for themselves. One coping mechanism that I hear again and again in the psychology literature is all around, they call it self-compassion and self-forgiveness. So helping a person work through forgiving themselves for the mistake is really important. Whether the person would need psychological therapy for that depends on the graveness of the experience, or the seriousness of the experience. What I found too was that a lot of participants really didn't know what to say to the individual. They really didn't know how to handle it. So if we can do some preparation for, even I've heard in the literature, and thank you again for the person who talked about the stress crisis management team, that's the kind of, we need to prepare like peer mentors in the organizations who have been trained or have some experience and qualities that could help people through these kinds of, when they're really feeling a lot of shame about mistakes. They can be trained, it can be something very discreet, and they can help an individual go through this. So that's one way of preparing, like educating people before they even start their careers on how to support others and how to be assertive and confident. And when it does come, when they see mistakes, and how to talk about mistakes, and to prepare them for how they'll feel. I'm going to leave it, Dr. Goldman, if you have some thoughts too. I can go on and on.
Yes, and I love hearing you go on and on. There are because I think there's some really great jewels of wisdom there. Let me add a couple more. To that person who says, "What can I do?" Special training, we can get to that. That's really important. But I find that one of the most helpful things to do is to help somebody reflect by giving an example of a mistake you've made, so that and not one that is so remote that it leaves the indelible impression that all of my mistakes were in the first 5 years of practice and I haven't made a single mistake since then, or I haven't had a bad outcome since then. I find that it is, and I'm doing this with my colleagues in a more open fashion. I'm trying to model good behavior, or empathetic behavior. I'm empathetic to my colleagues. I begin with them with the premise that we're all human and we all make mistakes. And one of the things that I do is share a mistake that I've made recently and how I felt when it happened and what I did as a result of it. As far as that special training is concerned, Diane, I think that if we want people to be specially trained, they have to get the notion that human beings make mistakes. And so I'd be very careful. There's a tendency in hospital culture to seek out the smartest person to be the leader, or somebody who is smart enough, brilliant enough that they may not be the smartest, because sometimes the smartest might be the most eccentric, but the best people person who's also very, very smart. And there is this tendency to once again reinforce the shame by picking somebody for whom there's a perception that they've never made a mistake. So I think if somebody's going to be offering counseling on that team, I think every member of that group has to know what it's like to have gone through this. And so the counseling model that I would use is the peer counseling model. What makes a health coach more motivating than a physician? Well, they've lost the 30 pounds or the 15 kilos that the patient's trying to lose, or they've quit alcohol. They've got into recovery just as the patient is trying to do. And I think you need to have the same thing when it comes to mistakes. Now, those are some of the personal things. The systemic fix begins by changing the paradigm. Instead of the paradigm that good health professionals never make mistakes, and so every time there is a mistake, it forces us to kind of react. What if we changed it around and said, what if we assumed that good people make mistakes often? Well, how would we change the system as a result? And once you flip that paradigm, then you can begin, I think, to incorporate open discussion about mistakes with safeguards, Diane, and do so in a warm and loving environment, and express appreciation for people coming forward, not so much in a whistleblowing way, but you actually want to encourage people to talk about their own mistakes, but to do that, you have to change the culture to be able to accomplish that.
It's interesting that we started this the questions, the early questions that came in were around, when you have the experience or that make the mistake, it's about learning from it so we don't make that mistake again, and really going down that let's change the system so that doesn't happen again. And we even talked about that the first time the three of us talked about this topic and what we were going to try to talk about, in that when we talk about the shame and the mistakes, the first thing people start talking about is reducing errors and patient safety and quality improvement. And it really does, as we've heard in the comments and we've heard from both of our presenters, it sort of ignores the individual. It focuses on the system, and yeah, sure, we don't want to make those mistakes again. We want to change the system so that we don't make those mistakes again. But it doesn't really address the individual. And now we're getting comments coming in that are saying things like, we need to stay close to the individual, not pull away from them, asking why people talk and gossip and chatter about other people's mistakes. Sort of those, we've gotten better over the years at changing the system and putting systems in place to prevent errors, but we're still not so good, and still asking the tough questions about how do we do the soft skills and really take care of people's emotions and stay close to the individuals.
I like that, staying close. I think that's a really, really important point, because we do isolate them, and we isolate them with silence. And you know, I've personally had the experience of wanting to participate in the M&M process, and the hand goes up and says, no, we have this other colleague who's very good at running M&M. And the message I got was, you caused the problem, he'll fix it. And that's not the way, I don't think that's the healthy way of dealing with it.
We've got another comment from Sharon Nettleton from Patients for Patient Safety Canada, since she's allowed us to identify her. She says, how can we create safety nets, too, that help catch the errors and mistakes before harm occurs, but also learn as individuals and teams, including patients and families? The harm to all when it occurs is significant. Thanks for being brave, Brian, and sharing. We need healthcare providers to come forward and talk about what has happened here, how it feels, where and how we go to get help. It helps to make this more of a normal situation and normalize this. Great comments about peer mentors from Diane. So.
And I think there was a question, thank you, Sharon, a question right at the beginning is how can we engage patients in this as well? And I think there is a role I think it is probably that much more difficult for health professionals to have the patient in the room when they're being open about their mistakes. But I think that is a goal we can have as well, where if we are using a model where we help those individuals get through this, part of it might be introducing the patient as well to help them, help them forgive themselves and seek forgiveness from the patient or the patient's family member. And I did want to also comment on Brian's comment about empathy. It is definitely talking about Brene Brown earlier in her TED Talk. She says one of the most powerful 2 words that you can hear from someone else is me too, meaning I've done that too. And very interesting that most of my participants talked about errors that were 30 years ago, many, many years ago when they first started. That is definitely, it's safer to talk about, well, I was young, I didn't know what I was doing, I know what I'm doing now. So very important to be sharing the mistakes that are in the relatively close past. So yeah, any other comments from out there?
Yes, we certainly have lots of comments. Danny's asking, the question that is asked is, why do people talk, gossip, or chatter about other people's mistakes? But I'm wondering if you learned anything in your research, Diane. Do people actually talk about mistakes, or is this just a perception of the person who has made the mistake that people are talking about it?
Yeah, good point. What they've told me is that they hear it themselves. They hear other people talking about others' mistakes, so they witness the gossiping. And the participants did have some thoughts. I asked them why they thought this was the case, and definitely one of them is making it real for someone else. Thank goodness it wasn't me talking about it, making themselves feel better about themselves, that it wasn't themselves, that they didn't make the mistake. And but for the grace of God go I, making that real. And so those were some of the thoughts they had about why people gossip.
Alice has said what helped her get through a situation like this was when the mother asked her, what are you going to do to help prevent this from happening again? She says that gave her the motivation to come back into work the next day, to look for better ways to do things. If it wasn't for her, she might have quit right there on the spot.
Very, very powerful example. Thank you.
And of course, hat tip and shout out to CPSI for its wonderful book on apologies and the components of an apology and the need for special training, supporting psychological support, not just for patients and families, but also for staff. I think this is certainly an important part of that apology process. Sincere, heartfelt, and what have you learned, and what are you going to do going forward? And I can tell you that when I go through the process of reinforcing the mask. Ultimately, it boils down to what can I learn that I can carry forward. So, and what can I teach others so that they can learn from my mistake. And I often find that's the most sustaining thing.
Doug, it's Elaine. If I can just pose a question sort of very relevant to what Brian and Diane have just shared with us, just for a moment. Brian and Diane, and maybe independently, at least over, if we just look at the last decade, and maybe, we could add a few more years to that, but let's see over the last 10 years, we've talked about it's not about shame and blame. We've talked about it's the system that we have to fix. Today, as Samina and others have said, we've brought such compelling evidence to the problem that is still very much there. So, very direct question. Have we moved forward, in your opinion? Have we moved this stigma? Have we moved this culture of, shame and blame? I mean, we've heard bullying today. We've heard some pretty powerful and discouraging, responses to Diane's research, etc. Have we moved the dot forward at all?
You want to go first, Diane?
Yeah. I think we have, because we're talking about it. I think 30 years ago we weren't even talking about mistakes. Mm-hmm. Now we're talking about it, and I think, as someone said in their comment, we've lost sight of the individual in talking about the system error. Mm-hmm. But I think in trying to analyze what went wrong, and by bringing patient safety to the forefront because of some of the work that was done 10, 15 years ago now, it's a conversation, and it's out there. But I think at the front lines, there's still a lot of work to do. In reality, there's a lot of work. There's a lot of silence. There's a lot of bullying. There's a lot of gossiping that's still going on. But maybe now's the time to focus on that. And it's not about reporting more. It's not about pointing out the mistakes more. It's just about dealing with them in reality, that it's mm-hmm. human, and that mm-hmm. we are all human, and we're going to make mistakes. I love this flipping the paradigm around, and Ron, I think it was Ron Collins, I apologize if that's not the right person, but who gave a talk at our virtual forum at Canadian Patient Safety Institute. He says, when a patient walks in the door, we shouldn't be saying how we're going to help this person, but what mistake are we going to make? Let's anticipate that mistake. Yeah. So that's another way of flipping it around. Mm-hmm. Mm-hmm. Brian?
So Diane, echoing what you've said, there are clearly the fact that we're talking about it, the fact that there are efforts to make the system safer, to build in additional checks and balances and safeguards, the fact that we're talking about transparency. These are all indications that errors are finally on the radar screen. I would also say, though, that the culture, there are many different subcultures in hospitals, and I'm sure many people who, or at least some who have signed into the webinar today, might be thinking, well, I belong to a healthy culture. I work in a place where we can talk openly about our mistakes, and it's a very loving and supportive environment, and that's great. And there are pockets where there's been positive change, but overall, and it's hard to kind of tap into or measure take the temperature of the entire culture. I think there's still a pervasive sense that errors are a marker for incompetence, and to go down that route and to want to make statements and and demonstrate that the system is to preserve the integrity of the system, and if that means casting doubt on the qualifications of a few people, that's okay, and that we're not particularly focused on the individual impact. I'm going back to what Doug said before, what Doug echoed in the comments that have been made, and so I think if we go back to addressing that, the individual and the impact of the individual of this whole process of uncovering and dealing with error, then I think we'll go a long way towards making the system safer. But it will always be, I think, tempting, unless there's a major paradigm shift, it will always be tempting to say, well, if we just weeded out a few bad apples, that we will make the system safer. And in the back of, I'm sure that there are leaders, in the back of the minds of leaders, yeah, but that's sometimes the case, and that needs to happen. And so you have the tension between the need to weed out and the impact of the process of searching for the people to weed out, and how that impacts on everybody else who you don't want to weed out.
Right.
We'll probably just take a couple more comments before we wrap this up in here. Give our presenters an opportunity for some closing comments. Lots of comments about using the language of pulling away, the individuals pulling away when they feel shame, or their colleagues keeping them close when a mistake is made. So certainly that statement that was made earlier is well received by the audience, and that concept. I think still lots of questions around how do we operationalize that in some sort of policy or program, but certainly lots of attention being given to that. Christy has said she always struggles with supporting managers with knowing the difference between supporting the human when things go wrong and when to decide that this person is just simply not suited for the work, for the safety of care. Do you have any ideas on this as managers are placed in what she describes as an ethically challenging position in this regard? Dr. Goldman stated that you hope as a healthcare provider not to be involved in a second event, as opinions regarding employee support can quickly start to turn.
Yeah, and certainly one way to deal with that would be to open up the process and openly encourage and reward everybody for talking about mistakes all the time. And one way to do that is the debrief. If you find a structured, neutral way of doing it, certainly in aviation they have a debrief after every flight, no matter how trivial or mundane. Puddle jumpers and jumbo jets, it doesn't matter. They debrief. This is what we did. This is where we flew. This was our altitude. These were the issues that occurred during the flight. And if we did that in a structured way in healthcare, I think we would soon discover that everybody is party to mistakes at all times. And hopefully we could get rid of the defensiveness. But I think if we did that, then people would be less fearful of reporting something. They would be less fearful that there would be bad consequences to a colleague if they pointed it out. But part of that process would mean instead of having a leader kind of pointing fingers and coming to a quick conclusion and then bringing the guilty party in for the last interview while they confirm, in order to confirm that this is the person that we can blame, gather everybody together in a room and no blame, no name, no shame. Just let's start a timeline and assume, instead of assuming that the people who made the mistakes are the last people to contribute to making the system safer, that they might be the most important, and ask them, well, what happened? And not in an accusatory way, and change your paradigm and adapt to a model of, I call it curiosity. Instead of saying, oh, how could you, turn it into, how did that happen? And I find that when I'm curious, I don't feel ashamed. And I think that the parties, everybody involved would be, and part of that curiosity is an astute leader asking the question, I'm not just interested in what happened, but not what you did wrong, but why did that seem like the best decision at that moment? So you're looking for the good in it, and that's part of rebuilding somebody's shattered self-esteem. Those are just some of the things that I'm thinking about that we could use to make things better.
You'd have to be really careful about the tone.
Yes, oh, absolutely you would. Do you want to say more about that, Diane?
Why do you think that happened? Pardon me?
Do you want to say more about that? Because I think it's important.
Yeah, no, in debriefing, the tone of what's going on, you have to be very careful and make sure, even if you're saying the words, why do you think that happened, it can still be perceived as blaming. I wanted to go back to the question that about the manager, and the manager definitely is in a position, very difficult position, when they see that the person who made the mistake is in distress. And a lot of what I read is that you should think about allowing that person time to recover and sending them home. So I'm not saying that you should send, I'm not giving advice on this, but this is what I've read, that sometimes what might be useful is to allow that person to get over this on their own. Like, not send them home as a punishment, but saying, you need time, and send them home with support. So, but you're right, managers are in a very, very difficult position to know how to cope, how to help that person cope with the mistake.
Comment that we'll take before we go into some closing comments is from Joanne, who's asking, and I'm not sure if you mentioned anything about this, Diane, but she's asking if you can comment on hospital administration and litigation, or fear of litigation, and how that limits the ability to apologize or to talk openly about this. I'm not sure if you mentioned that, but that's the last comment that's come in.
Yeah, interestingly, fear of litigation did not come up in when I was talking to participants. It did come up, but kind of, oh yeah, and I'm worried about getting sued. So that is definitely a component. And as Doug mentioned at the beginning, I did some work earlier in my career at the Canadian Medical Protective Association, and we got calls every day from physicians worried about getting sued. It is a terrifying for any health professional to get that letter saying there's a complaint. So that I'm not sure how much that is fear versus shame. So it's more the outcome of a mistake rather than the part of the shame that people feel. But very, very important point to bring up, that fear of litigation is very much a part of the reaction of making a mistake.
I would, Diane, in echoing some of the things you've said, I would also add that from the perspective of a leader or a CEO, there has been for a long time a great deal of tension between efforts to move towards apologizing and the concerns over litigation. And of course, I know very well that apologies are, as constructed under provincial legislation, are exempt from litigation, are not admissible in court. And but there's certainly a fear that talking too much about a mistake early on, particularly with the family, might have an impact on the discovery process. And even if there are regulatory or legal safeguards, I would also say that on a personal level, there's nothing like the process of having to relive what happened again and again in examinations for discovery and reading colleagues that are critical of your management to re-experience the shame. And in that sense, and that's not to diminish. That's not to say that the experience of health professionals who are sued is in any way comparable to patients and families who at some point resort to the courts and often find that the process is not a particularly good one for them. But I think it's worth mentioning that certainly colleagues, my colleague who was sued for the bowel obstruction, the patient with the bowel obstruction, certainly talked about reliving the experience again and again through examinations for discovery.
Well, why don't we take this as an opportunity to wrap it up, and we'll hand it over to Dr. Goldman and Diane for some closing comments. And I just want to say that when we were talking about this before we started the session, I was preparing our speakers to be prepared for maybe not seeing a lot of comments or questions from the audience. And I think we were certainly proven wrong. It's been a little bit overwhelming to see all of the different, very personal, very emotional comments that people put in. And I'm still a little bit stunned by that first question, that I am and I feel question, and how quickly how many people typed stuff in, how quickly they came up with these words, and how harsh the words are. I still see some of them on my screen here, and the words that they were using to describe themselves are really taking these things extremely personally and internalizing some of these feelings in a very powerful way, and their ability to share. I mean, it was really, I'm still a little bit stunned by that first question and the response that we got from that. So any closing comments? We'll start with Diane.
Thank you, Doug. And I too, I'm very, very grateful and very moved by your participation at the beginning as well, and some of the comments throughout. And for me, I just want to end with my final thought on really. Yes, as Elaine said, we have come a long way with the systems thinking. I think that's really done a lot of good to make us look at mistakes in a different way. But somewhere along the way, we've forgotten the individual. We want to stay close to the individual, as our today one of the audience said. We don't want to pull away from them, and we want to bring back the humanness of mistakes. We've dehumanized mistakes. We want to bring the human part of the mistake back in.
Mm-hmm. That's such an important point.
Any final thoughts from you?
Yes, I would say that shame is real. I've experienced it. I've seen it vicariously through my colleagues. Shame is not only personally awful, it's a teacher. No question, it does motivate us not to make the same mistake. It leads to vigilance, but it also has a corrosive effect. And I would suggest that it also has, not only on the individual, but also has a corrosive effect on our ability to uncover errors and to deal with them more preemptively. So I think it's time that we address this issue, and that's why I'm glad to find that there are researchers like Diane Aubin who are interested in this subject and can't wait to find out what more she can accomplish down the road.
Dr. Goldman, it was really a pleasure and an honor to have you on our show, and thank you, Diane, for bringing this topic to our attention. It was an interesting topic when you first brought it to me, and it certainly became much more than just a simple interesting topic by the end of this session. So thanks very much to both of you for such a great presentation.
Mm-hmm.
Thank you, Doug.
Absolutely.
Thank you, Doug.
And thanks to the audience for your contributions. So we'll close this off now, but really the audience, you really made this such a very special presentation today. So thank you very much to everyone that was out there. We do our webinars every Wednesday at 11 a.m. Eastern Time. And as I said, it's always great if you can watch live because your questions and comments really enrich the discussion. But if you can't watch live, we do record the sessions, or if you do have to leave early, we do record the sessions so you can come back to them and make them available after the fact on the Knowledge Exchange Network. In the next few weeks, we've got a great lineup of webinars. Next week, February 18th, we'll be hosting a webinar on Jordan's Principle titled Ensuring First Nations Children Have Equitable Access to Services Through Jordan's Principle. This webinar is based on a report that was just released this week on Monday, I think, or Tuesday, and it was a document endorsed by UNICEF Canada, Assembly of First Nations, Pediatric Society, led by researchers Wanda Singh and Lucy Locke from McGill University, and we'll be welcoming Wanda and Lucy to the CAFC Presents virtual stage to take a look at what the status of the implementation of Jordan's Principle is, and based on the research that they've been performing over the last few years. Following that, we've got a session titled Caregiving and Resilience, Supporting Youth in Adversity, in Transition, and in the Community, where we will welcome back Dr. Christine Weckerell, who you might remember from our conference in Calgary this year. But also joining Christine is Chris Musquash and Abby Goldstein. And the week after that, we'll have Jeanette McDougall and Patricia Baldwin with a session bringing their research on quality of life for youth with chronic conditions, learning from youths and parents' perspectives. So it'll be a great presentation of some of the research that they've been doing. We were hoping to have Virginia Wright, but she's in Australia and got the time change wrong and didn't realize it was 2:30 in the morning for her, so she won't be able to join us. But Jeanette and Patricia will be joining us for that stage. So thanks again to everyone for joining us, for making such a great presentation, and hopefully we'll see you back here next week. Thanks, everyone, and goodbye.
Thank you, Doug. Bye-bye.
Thanks, Doug. Bye-bye.
You're welcome.